Thank you. I want to say thanks to Kate and Jody for inviting me to talk. This has been a really great day already. I'm looking forward to the rest of the afternoon. So I wanted to talk a little bit about how am I advancing these? Just with the clicker. Okay. About an emerging model for direct-to-patient engagement in research that we are piloting right now at the Broad Institute. And then I'll say a few words about some of the ethical and legal and policy challenges that we're really sort of butting up against and grappling with right now. And thankfully, I'm happy to hear that lots of us are thinking about the same things. What am I doing? There we go. Nope. How do I advance? Oh, this thing. This thing? See, it's not just me.
Oh, there we go. I think you have to move it down. It's because this thing's pulled out.
So I have to,
I think it will work
is that
now.
forward and back?
Yep.
Okay.
There you go. Sorry.
It's okay. So since the completion of the Human Genome Project, we've seen quite a bit of progress, I think it's fair to say, in unpacking the genomic drivers of cancer. Some of these advances have led to some pretty incredible advances, including a growing list of highly effective drugs that are tailored to particular molecular characteristics of a given tumor. But if the end goal is to be able to interpret every patient's genome, cancer genome, and to use this information to identify optimal treatments and anticipate and preempt resistance, we're still a long way off from being able to get there. And to get there, we at the Broad believe that one of the important elements is that we need detailed molecular and genomic characterizations of tens, if not hundreds of thousands of tumor and germline samples along with medical information. We need to be able to learn directly from the experiences of cancer patients. It's not sufficient just to have tumors or just to have germline sequences. We need to be able to integrate this data. So unfortunately, while patients and cancer patients especially are more willing than ever to participate in research, there are really few opportunities for them to do so, and this gets to our institutional challenges. So for example, only 5% of cancer patients right now participate in clinical trials, and 85% of cancer patients approximately are being treated in community settings. So rather than large academic cancer centers where they may be offered opportunities to participate in research. As a result, their tumor samples collected in the course of their care are basically sitting in local pathology departments and largely going to waste, if you will. So most patients are not being offered opportunities to participate in research. Most tumor samples are not readily available for study, and we're failing to systematically learn directly from the experiences of patients. So a little over a year ago, Nick Wogley, who's a medical oncologist at the Dana-Farber and an investigator at the Broad Institute, launched a pilot project that sought to address this challenge by engaging patients directly in research through social media and utilizing social media and other online tools. So his theory was that today there are a lot of patients, many patients are internet savvy. Many of them are connected to other patients and patient organizations via social media. So could we leverage those tools to recruit and engage patients in research? And could it actually help to democratize research, at least in the sense of giving patients opportunities to participate regardless of where they live or are being treated? So can it help us to get at that 85% of patients who are treated in community settings? So this is the website for the Metastatic Breast Cancer Project. When you go to the site, it says, do you want to help transform our understanding of metastatic breast cancer? You click Count Me In, and that brings you to a basic survey that was actually designed in consultation with many patients over the course of some months. It's a list of 16 questions that patients answer in, on average, 6 minutes. It asks some really basic information about their demographics and when they were diagnosed with metastatic breast cancer, what drugs they've taken, et cetera, et cetera. If they've had any extraordinary responses, how long they've been living with cancer, et cetera, et cetera. They send that online survey back, and the next thing that they receive is an online consent form. The consent is really very broad. It's pretty similar to what we heard earlier this morning with the Mayo Clinic Biobank. It asks participants for permission to collect a saliva sample, obtain stored tissue samples if they have them, and perform genetic testing, both germline testing and tumor sequencing. It also requests them for copies of their medical records and for permission to link those records with their genetic testing results. And patients also consent to the use of their data in future research studies, including studies that are not in cancer, and to share their data with public databases. Those patients that consent are then sent a saliva kit and asked to mail back their saliva sample, and their medical records are obtained by the metastatic breast cancer project team and centrally reviewed and abstracted. Tissue blocks are requested from the local pathology departments by the team, and then we get into the genomic analysis and interpretation. So we were really kind of blown away because when we launched this project, we didn't really know what to expect, to be honest, but we were really surprised to see an incredible response. And it's been just about a year now, and over 2,900 women and men with metastatic breast cancer from all 50 states have joined the MBC project. There are also some really interesting things with just the basic online survey data. Has already helped us identify some really interesting subpopulations to study. So, for example, there were a surprising number of individuals who had been living with metastatic breast cancer for more than 10 years. So it'd be interesting to know why have they done well. We've already identified a couple of drugs that have popped up in terms of medicines that people seem to be having, at least some subsets of individuals seem to be having an extraordinary response to. And there are some other interesting issues. But just from like very basic patient reported data, it's starting to help to drive some interesting hypotheses that we can then go on to test. This effort has been really a collaboration. We started out just working with a couple of different patient advocacy groups, and that has grown over the past year, and there are now 20 organizations that are affiliated with the project. We've engaged patients and advocacy groups from the very beginning in conceiving and designing and implementing and testing and refining the project, including, like I said, the initial survey. And it's really kind of amazing that one of the other striking things is that we've been tracking how patients sign up. And it's really word of mouth that is bringing in most of the patients. We do not advertise for this project beyond the initial Facebook page and the initial like online media sort of work, but we're not doing any like advertising. Most of this has actually been by word of mouth, by the patients themselves that are actually bringing people to the website and talking about the project online and on Facebook chats and things like that and Twitter. So these are just some examples of some of the really great responses we've gotten from the patients. I want to live and watch my children grow up, but if I can't, then I want to leave a legacy and a cure. As someone who does not live near a research center and therefore cannot easily participate in trials, I finally feel like I can contribute. Amazing how happy that little box makes you feel. That's the box that they return their saliva kit. I feel like a 2-year-old. Let me help. I feel a sense of pride and belonging because of this. Give us hope for the future, and if not for some of us, for our families. So there's really been just an incredibly powerful and overwhelmingly positive response from the patient community. All that said, there are definitely challenges with doing this kind of direct-to-patient project, and especially when we think about developing out additional pilots and scaling this effort. What if we wanted to do this for all cancer patients? There would be lots of challenges with that. First of all, coming up with the funds to sequence all cancer patients, but aside from that, there are a lot of issues with scale. I'm going to talk about the last two in particular. But obviously, governance and relatedly, building and maintaining patient trust are huge and things that we have been grappling with all along. I think one of the really great things about the MBC project is that there was a huge effort to communicate. There have been not just online things either. We've done a lot of in-person things, bringing groups of patients together to talk to them and creating different forum for people to come together in person as well as online. And it's sort of one thing to do it with one particular community, but as this thing has grown, and even now that we're 3,000 people, I'm starting to have my own concerns, like are we outpacing ourselves, and can we maintain that enthusiasm, that trust as we grow? And then let me talk a little bit about what I think is one of the biggest challenges with this effort, which is collecting and abstracting medical records, which, as many of you probably know, is a painstakingly difficult and laborious task. Despite the major federal push under this administration to digitize our health records, we are still dealing with paper. When it comes to research, we are still receiving these medical records via fax, predominantly. Sometimes a PDF, a scanned PDF, that we end up having to print out and then manually abstract the record, the various elements of the record that we're interested in for research purposes. So why is this the situation we're in? I think a lot of the people in this audience are probably aware of some of the history, but Congress passed the HITECH Act in 2010, which included a $30 billion incentive payment program to offset the costs of going digital, and we doled out subsidies to providers between 2010 and 2014. And this was very successful in some ways. By 2014, more than 70% of hospitals and doctors' offices had adopted EHR systems. That was up from 17% in 2008. But the resulting system failed to deliver on the promise of these systems to enable interoperability, which was one of the stated goals of creating this system. Part of this was a failure by design. So these systems were primarily designed to optimize billing rather than to facilitate data sharing. They were designed primarily in the interests of, not really in the interests of doctors and patients. And there were also some perverse incentives on the part of EHR vendors where there wasn't really an interest to build in, say, an export button into these systems because, of course, that would be a way for providers to then easily switch to another vendor if they wanted to. If it was easy to export the data, it would be easy to switch. And this is partly what this article is talking about, that there's an incentive to lock in customers by making it difficult for them to switch to competing vendors. So sort of to exacerbate this problem, there's also been sort of increasing market consolidation, which also impacts incentives for change. So Epic and Cerner today have come to dominate the market, for example, for large hospitals, and I think this is now a little bit outdated. I think now some people have predicted that Epic will have a virtual monopoly in terms of large hospital systems in the next, say, 5 years. So what are the solutions? What are the policy levers that we can pull to try to fix this problem? There are really sort of two approaches that people have been working on. The first really emphasizes interoperability. And that's basically CMS, the incentive payments program, the meaningful use program that probably most of you know about, that basically creates incentive payments to providers that adopt certified electronic health records and achieve meaningful use. And as part of that, the ONC, the Office of the National Coordinator for Health IT, specifies the capabilities and functions that EHRs must perform in order to be certified. And so there have been various iterations of meaningful use and trying to sort of ratchet in these systems to try to get them to make more of their data easily accessible and interoperable across systems and to be able to move data more easily. Unfortunately, the process has been pretty slow. And the real limitation, especially from a research context, is that it enables access and sharing of a very limited set of data right now. And that's basically this, what's called the CCDS, or the Common Clinical Data Set, which is actually just a subset of about 21 elements of a medical record. The second approach, and this is one that organizations like Get My Health Data have started to talk about, it's really about making consumers more aware that they have a fundamental right to their complete medical record under HIPAA, the HIPAA privacy rule. The language is actually quite broad. You have a right to access and obtain PHI in a so-called designated record set, which includes any information used in whole or in part by or for the covered entity to make decisions about individuals, and it must be provided in an electronic form and format requested by the individual if readily producible. If readily producible is an important caveat, though. So when we compare these approaches on meaningful use, you can get standardized machine-readable data, but it's limited. And so from a research perspective, that data may be insufficient for patients, even monitoring their own health. But it's definitely insufficient for many research initiatives. It's not sufficient for what we're trying to do in cancer research. On the other side, you can leverage HIPAA right of access and patients could help drive, potentially, the liberation of their own data and could donate it for research purposes if they wish to. But then we're going to be dealing with totally unstructured data and have to deal with cleaning the data on the back end. So I've been thinking a lot about what is the delta between this CCDS that's in structured format and the DRS. Can we start as a research community thinking about, for the sake of developing learning health systems, what are the other elements of the healthcare of the health record that we want to see standardized and more readily shareable? And also, if it were really easy for patients to make HIPAA right of requests, could we leverage that to help create more demand for liberating medical record data for research? I'll skip this for the sake of time. Do I have one more minute just to talk about return of results? Okay. So the other thing I want to talk a little bit about is return of results. Return of results can be thought of as many things along a continuum. There's public release of data. There's return of general study results to patients. Those are things I think the NBC project and Count Me In initiative at the Broad are already embracing and prepared to do. And then there's return of individual results to patients and the return of incidental findings. And those are much trickier from a regulatory perspective. So CLIA, the Clinical Laboratory Improvement Amendments in 1988, they set quality standards for laboratory performing clinical testing. And research laboratories are generally exempt from CLIA so long as they do not report patient-specific results for the diagnosis, prevention, or treatment of any disease or impairment, or the assessment of the health of the individual patients. CMS has interpreted this fairly strictly and has concluded that any return of results would violate this exemption, including a situation where patients are counseled. So they're given their results, but they're counseled that the results are not for treatment purposes, and they should seek additional testing at a CLIA-certified lab. So some have taken issue with this. SACHARP, the Secretary's Advisory Committee on Human Research Protections, has actually challenged this and has been pushing CMS to revisit this and has said, if you're not returning the results for treatment purposes, that's not in violation of the regulations. I don't think CMS is going to necessarily budge on this. There's a big sort of debate about this issue in HHS and across the government. CMS could, in theory, exercise enforcement discretion and allow research labs to refer participants to follow-on testing. Researchers could just start conducting all testing in CLIA-certified laboratories, but that would be very, very expensive. And another way we could maybe sort of move this along is that researchers could build in two-step testing into their protocol where individuals consent up front to have testing repeated in a CLIA-certified lab in the event that the research reveals potentially actionable results. I actually don't know where I fall. I don't have a strong, I think there are ethics on both sides of this debate. I think it's a really important issue. Right now, we are conducting our testing in a research laboratory. And we have had a few requests, though, from patients asking if we could return data. When we explained to them the regulatory, that we can't by law, they're okay with that. But we are seeing an increasing number of patients ask for that, and people starting to think that this is part of the quid pro quo of participating in research, and that we should be thinking about returning more to individuals. So I will end up with that, but look forward to the discussion. Thank you.